So welcome to everybody to Women on Wednesdays. This is a bi-weekly advocacy campaign to advance policies for women in Louisiana. Each week we host groups of advocates so that we can learn about these key issues that are affecting women across our state and the impacts of proposed legislation. Our goal is to give you the information and the tools that you need to influence the legislative process and to hear from the state lawmakers who are doing the sometimes thankless work of trying to move these policies forward. Just a couple of housekeeping things. We are recording this and we will share the link with you and post it on our YouTube channel. You can also find links to past Women on Wednesday recordings there too. And if you have any questions, you can type them into the chat or use the raise hand feature. And Ms. Robin will ask our guests the questions when we get to that part. So we have everyone muted and we ask that you just stay on mute until it's your turn to talk or until you are called on to ask your question. So Women on Wednesday is a project of Lift Louisiana. We are a reproductive rights organization whose mission is to educate, advocate, and litigate for the policy changes that we need in our state to improve the health and well-being of Louisiana's women, their families, and their communities. This is our third year doing Women on Wednesdays. This is our second year doing Women on Wednesdays on web. So we've worked out a few kinks and hopefully you enjoy yourself this evening. We're really excited for this session because we are going to be talking to some experts and one of our legislative champions about addressing maternal health in Louisiana. And particularly, we're going to be kind of focusing on the Mama Plus policy agenda, which you will hear a lot more about from our speakers. So joining us this evening is Ashley Hill Hamilton from the Birthmark Doula Collective, State Representative Matthew Willard, who represents District 97, and Kylie Mayfield from the National Birth Equity Collaborative. We're going to start with State Representative Matthew Willard, who was elected in 2019 to represent District 97. He's a lifelong resident of Gentilly. Hopefully he is representing some of you today. And he was raised in a family that values faith, community service, education, and altruism. Both of his grandparents were civil rights leaders and lifelong educators, so he comes from good stock. And one of his legislative priorities since entering the legislature last year is to address the maternal mortality crisis that's disproportionately impacting moms of color. So with that, I am going to let Representative Willard talk a little bit about his bill, which is HB 190.
Thank you, Michelle. Michelle, can you hear me?
Yes, we can hear you.
Okay, perfect. Good evening, everybody. Good evening, everybody. It's a pleasure to be here with you this evening. We are still on the floor, so apologize for the noise. The good news, I mean, it's an honor to be here with you this evening, and I see Kylie and Ashley on the call right now. We're actually working together on House Bill 190, which would improve access to midwifery and doula care for Louisiana residents. And we have some really good news today. Maybe an hour ago, we actually advanced that legislation from the House floor. So HB 190 is now on its way to the Senate side. And overall, we're trying to improve the birthing outcomes in Louisiana. So for me, during my campaign, I came across statistics that really puzzled me and then later upset me about the poor birthing climate that we have here in Louisiana. We have the highest maternal mortality rate. We have the second highest infant mortality rate. We have a high number of C-sections. We have a high number of preterm deliveries, low birth weight babies. So I made it one of my missions to try to address some of these issues that are contributing to the overall poor birthing climate here in Louisiana. So what HB 190 does is it says that any healthcare coverage policy in the state of Louisiana that provides for pregnancy benefits has to also include midwifery care, insurance reimbursements for midwifery care. We also have language in my discussions with some of the midwives in Louisiana. I heard that they had trouble getting reimbursed at in-network rates. So we have language in the bill that mandates that they cannot have discriminatory language in a contract that prohibits a midwife from being reimbursed at in-network rates. Another big priority for us was to push for insurance coverage for doulas. And I was very passionate about it. I know Ashley, I know Kylie, we were all super passionate about it. We wanted to see it happen. You know, I know how the legislature works. I'm on the House Insurance Committee, and I know that the insurance companies typically get their way. So when we initially filed HB 190, we had a mandate in there for doula reimbursement in insurance policies. When I took that draft of the bill to the insurance companies, they said that they would prefer us to set up some type of board, registry board, so that we can start sort of a certification process in Louisiana for doulas, so that they can go back and look at some of the benefits as far as improving birthing outcomes and probably some cost benefit analyses as well. And so, you know, as a group, we all discussed it. We decided that that was okay because this is a step forward. It's really progress. And so we removed that insurance mandate for doula care and went forward with creating a registry board. And so the hope is that in the next year or so, the insurance companies will come on board and say, hey, we are ready to start reimbursing for doula care. There's a lot of studies, there's a lot of data that point out the benefits of having access to midwifery and doula care. And actually a March of Dimes report, as well as an LDH report that studied the poor birthing outcomes in Louisiana, recommended as far as ways to improve our birthing climate in Louisiana, to improve access to midwifery and doula care. So I'm really proud of the bill that we have right now. I think we have a really good shot to make this a law, and then moving forward, I think we have a really good chance to get reimbursement coverage for doula care. So that's really all I have. You know, I appreciate everyone on this call. I appreciate your passion and your dedication to women issues, especially as it relates to the birthing community. I want you all to know that I'm a champion of your cause, and as long as I'm in the legislature, I'll keep fighting.
Thank you so much.
And thank you, Michelle. I really appreciate everything that you do as well related to legislative efforts. And I'm here anytime you need me, so just let me know.
That's great. We'll let you go because we understand that you're, you know, still on the clock. But if we get any questions specifically for you from folks that are attending,
okay,
and we'll send them to you in an email and connect you with those folks so that you can, you know, communicate with them a little bit more about your efforts. So thank you.
Perfect. Okay, I appreciate that. Y'all have a great evening.
Awesome. Great. So I'm going to introduce our other two speakers now, and I think that both of you are co-hosts and therefore have the ability to share your screen. So I'm going to spotlight. We'll just see if we can pin both of you so that everybody can see you. There we go. Excellent. All right. So I'm really excited to have both of these amazing women on Women on Wednesday. Ashley Hill Hamilton is a native uptown New Orleans mother of two with 16-year age gap. So good. That seems challenging, but also like maybe you have a built-in babysitter, which, you know, could be helpful, I think, considering our dismal childcare access in Louisiana. Ashley serves as a reproductive justice activist who's committed to creating methods which prioritize dignity and equity to improve the healthcare experience for Black birthing people. Ashley is also a lactation counselor, a writer, and a member owner of the Birthmark Doula Collective. And then we also have Kylie Mayfield, who's the birth equity analyst at the National Birth Equity Collaborative. She has an MPH from the Tulane School of Public Health, where she was also a Center of Excellence for Maternal and Child Health Scholar. And her goal is to impact maternal and child health for marginalized communities. So I'm going to welcome you both, and it's up to you which of you wants to go first.
Thank you for having us today, Michelle. And we're going to tag team it. So we have one presentation that we'll be going through.
Look at y'all, so organized. I love it. Thank you.
Let me go ahead and share my screen. Do you want me to share my screen, Ashley? Is that okay?
Please.
Okay. Everyone see the screen?
We can, we're good.
Okay, let me go to present. No, sorry. Okay. So the title of our presentation is Addressing Maternal Health Disparities in Louisiana. Oh, here we are. And I'll introduce, Michelle introduced me, and I work at the National Birth Equity Collaborative. And I will say that MBEC is a New Orleans-based nonprofit that's focused on creating solutions that optimize Black maternal, infant, sexual, and reproductive well-being. And we shift systems and cultures through training, research, technical assistance, policy, advocacy, and community-centered collaborations. And the work that we do, it's on a local, state, national, and global level, because we recognize that adverse or undesirable pregnancy, birth, and health outcomes for Black mamas, babies, and their villages needs to be addressed on all levels. And I'll let Ashley share some information about Birthmark doulas.
Thank you, Kylie. So my name is Ashley Hill Hamilton. I'm the Director of Advocacy and Outreach for Birthmark Doula Collective and the New Orleans Breastfeeding Center. A lot of people have heard of both organizations separately. However, recently we have actually merged forces and we are now one organization so that we can better serve our community and extend the reach of our services. Birthmark focuses on providing birth doula, prenatal, postpartum education and support to community members, our clients surrounding lactation, also surrounding their options to birth, counseling them through that. We also provide continuing education credits for medical professionals through our Grand Round series. So we also provide childbirth education for not only our community members, but also people in the community who serve birthing people. This past year, forgive me as time seems very fluid right now, since the pandemic, we have actually introduced our first cohort of perinatal community health advocates so that we can actually extend our reach to be able to serve our community even better. And what a perinatal community health advocate is basically a doula on steroids. So a perinatal community health advocate is able to not only offer that physical and emotional support during labor, but also they're trained in things like blood pressure checks, mental health assessments. They're now being trained to do glucose testing and also skilled in making referral systems. Many of those things are things that doulas have done innately. However, doulas are not trained medical professionals, and the perinatal community health advocates are learning some skills that will be able to help reduce maternal morbidities in the community. I'm sure that I'm leaving many things out. We also have a nurse advocate who who is a registered nurse who actually is able to go out and serve our clients and do assessments prenatally and postpartum to see if they need greater support, if more referrals need to be made. So those are a few things that we're doing internally in the organization. We also make it a point to support people regardless of what their options are. I'm happy to get into it a little bit later, but there's a huge misconceptions about doulas that we only support one type of birth, or that we tell people what type of birth to have, or what decisions, or people really believe that we only support natural births, and that's not true. We actually are not in the business of telling women what to do with their bodies. So we actually support people across the spectrum and help you to receive the information that is best for you to make the decision that you and your family are most comfortable with. So I'm going to jump into just some of the issues that we tackle surrounding maternal health. One of the things that I am, and I'm not exactly on par with the PowerPoint right now, so please forgive me, but I'm just going to speak from the heart. Some of the things that we actually work tirelessly on is the reason that I got into this work was through my experience as a parent. And as I go into the community and I talk to people often, the reason why they seek doula support, the reason why they seek other birthing options is to either improve a birthing experience that they have previously had, to try to avoid having an experience that they've heard one of their family members or community members have had. And we really have a lot of people in the community, especially Black women, who are afraid to give birth. And as the statistics have continued to come out, and we know that Black women are 3 to 4 times more likely to experience a death related to childbirth, a preventable death related to childbirth. There is this sense of fear that is connected to birth. And that's not what we want at all. We want people to know what their options are. We want people to feel safe. We want people to feel empowered. We want people to feel excited and enthusiastic about their birthing experience. And a part of that is allowing them to have the options that they need and that they deserve to receive the quality of care that they deserve. So some of the barriers that come up for people receiving the quality of care that they need is access to options. And when I say access to options, I mean to the provider. You should be able to choose the provider of your choice. You should be able to work with the doctor or the midwife of your choice. I often give the example of when you're going to the hair salon and the amount of time and energy and effort that goes into choosing the person who's going to do your highlights just right, who's going to make sure that they cut your hair just right. And for our bodies, we want to have that same type of care, and we should be able to make those decisions in that same way with that same amount of regard. We should be able to have a provider who is not making decisions for us, but is making decisions with us. So there are OBGYNs that work in that way. There are licensed midwives that work in that way. There are nurse midwives that work in that way. And every birth, every practitioner is not for every person. So as I mentioned before, some of the misconceptions that go along with doulas is doulas only work with midwives, or doulas only work with this type of person. We work with whomever our client chooses, because it's not our birth, it's not our decision, and we want people to genuinely feel empowered about decisions that they have. And the only way you can feel empowered is if you are the person leading that decision. So the person that is best for me, I may have had an amazing experience with one person, and you may have a different experience because your needs are different, because your history is different, your trauma is different, your goals are different. So everyone is going to need to make a decision based on what works best for them. Based on what works best for them. When we get into social determinants of health and racism, we find out that there are things that actually prevent people from getting the care that they deserve, from getting the care that they need, and from getting the care that they want. So I actually have been really privileged to be able to work on both sides of the spectrum. I've had a unique opportunity to actually work with people, with birthing people through direct services and actually being their doula and providing care for them and sitting in their living room, sitting at their kitchen tables, eating with their families, talking to grandparents, talking to partners, talking to cousins, aunts, children. And on the other side of the spectrum, actually, sometimes all at once, I've also had the opportunity to work with healthcare providers who were serving those clients. And one of the things that I found out is I actually worked in a program where simultaneously I was working with a hospital that many of birthing people in a specific community in rural Louisiana were seeing providers at this hospital. And through this hospital, we were actually told some of the things that we could do as doulas to help better serve their clients, or to help their clients to have better outcomes. And one of the things that we continuously heard is that clients were not attending their postpartum visits. That's something that we continuously heard, is that, hey, if you can get the women to their postpartum visits, that would be great. That's what we really need. So as we started talking to these clients and actually talking to these people about like what some of the barriers were of why they weren't attending their visits, we were able to find out some unique things. Some of the unique things that we were able to find out is one of the barriers was transportation. So at the doctor's office, we would often hear that there is Medicaid transportation. So you do have access to transportation if you don't have a vehicle. And oftentimes the hospital would be 30, 40 minutes away from that person's home. So if that person did not have a vehicle, they were not able to easily just get in their car and get to that appointment. What we found out about the Medicaid transportation that was available is oftentimes they would give you a time range in which they would pick you up that would be like inside of 4 hours. So you would just have to stop your entire day. You would have to wait for this transportation to pick you up. And then once that transportation picked you up, it was an all-day event. You weren't necessarily prioritized. There was no priority given to the time that your appointment was. Oftentimes people would either be late or completely miss their appointment altogether. And then having to wait to get back home, oftentimes maybe having someone else to watch their small children, they would have to wait all day. So this was literally maybe an 8 to 10 hour event of just going to a doctor's appointment, which really isn't feasible for anyone. And it's not an option that I probably myself would have chosen. I don't have 10 hours out of the day to dedicate to a doctor's appointment. So that was one of the barriers that was coming up, is that the transportation was unreliable. Another barrier that came up with people going to their postpartum visits, and I bring up the postpartum visits because a lot of the maternal health disparities that lead to maternal deaths that happen in the postpartum period. And a lot of physicians that we've worked with believe that this can be avoided if people are invested in their care in the postpartum period. And if they attend that 6-week visit, for starters, that a lot of things can be identified. We can talk a little bit more about why we need more than just 6 weeks of why we need a visit to extend past 6 weeks. However, another thing that came up was childcare, that oftentimes birthing people or postpartum people were not able to bring their children with them to the doctor's appointment. So if you think about the time span that the transportation takes to bring, or even if a person does have transportation, if they don't have childcare for their baby or for their other children, and they're not able to bring them into the office with them, then they're not going to an appointment. And that's another barrier. One of the third and actually most common things that I heard, one of the most common things that I actually heard, and I'll move on quickly, but one of the most common things that I heard was, I don't like the way that I was treated. And after I had my baby, I never wanted to see that person again. So that's when we bring up issues of racism, we bring up issues of equity in the way that people are treated by their providers. So oftentimes people are being paired with providers, not that they chose, but that were assigned to them, or that they had to see based on their insurance, the person who was available at the time, not a person who they had been able to cultivate a relationship with. And because they haven't been able to cultivate a relationship with that person, or because maybe there was not a synergy in that relationship, people really did not have a good experience. People have been talked down to, they have been told things about their bodies that they didn't agree with, or they had just an overall negative experience and were not given the right to choose and said that I'm never going in and seeing that that person again, thus not attending that visit for that reason. Next slide, please. So I briefly touched on these things already, but in the United States, Black women are 3 to 4 more times more likely to experience a pregnancy-related death than white women. And we also know that these deaths many of them are preventable. The reason that these deaths are preventable is because, I don't know if you all have seen, there have been many initiatives over the years that have shirts and their hashtags, and it's all over social media, but it's listen to Black women. We really need to be seen as the agents of our bodies. We have known ourselves longer than any other person, so we know intricately the stories of our bodies. We oftentimes know the stories of our parents' bodies and things that they have experienced. So if a person is coming in to provide health care for us, they have to make those decisions with us. They have to listen to us and say that and understand that we know what's happening to our body so that we can work together on that. I remember an example. I was working with a parent who had just given birth to twins, and she explained to her provider that she felt as though hot lava was seeping from her brain, and they gave her a Tylenol. It turned out that she was having a brain aneurysm is what was happening. But they said, oh, like assuming that she wasn't explaining it right, or that she was over exaggerating the pain that she was experiencing. And they gave her a Tylenol and sent her home. So when we say listen to people, listen to what they are saying, and knowing that people are the agents of their own bodies and that they know what's going on, and genuinely listen. We've also seen research that's come out that has explained or dictated that Black women are perceived, and there are also books that say still that are being taught in medical school that Black women experience pain at a lower threshold than women of other races. And that's just simply not true. Or that they are seeking drugs and medication and making up symptoms to receive medication or drugs while in labor or in the postpartum period, which is also something that is just rooted in racism and is not true. So we really want to make sure that the decisions that are being made and people are being listened to, and they're able to be a part of their healthcare in those decisions, and that we are deeply, deeply, deeply working towards dismantling systems of oppression and racism surrounding maternal health disparities. In the state of, I'm sorry, can you go back 1 second? I just wanted to state just really briefly, in the state of Louisiana, it's not on here, but in the state of Louisiana, our cesarean section rate is extremely high. About 40% of our births are result in non-medically necessary cesarean sections. And what a non-medically necessary cesarean section is one that is not done in the effort to save a life. It is not one that is absolutely necessary. So for example, if a person were to have a cesarean section because it was a date that was most convenient for them and not something that would actually save their life, that would be a non-medically necessary cesarean. Whereas a cesarean that was done to actually save the life of a baby whose heart rate was decelerating, or so on and so forth, then that would be a medically necessary cesarean section. And the Louisiana Department of Health and Hospitals actually came out with a statement a few years ago to support actually work done around that, to show that what's called the cascade of interventions is something that was actually contributing to that. So by allowing people to labor in a more natural state without introducing unnecessary medications in the beginning of their labor, things that will often slow down their labor, could help with that. And doulas have also been said to help with, it have been documented to be able to help with reducing the cesarean rates, simply because we talk to people about their options, how to labor, how to birth, what the implications are of non-medically necessary intervention, so on and so forth. There's been a lot of work taking place in the state of Louisiana over the past few years to really address maternal morbidities and also non-medically necessary cesarean sections. There is the Louisiana Pregnancy Associated Mortality Review, who also called PAMR, who is reviewing case studies and actually seeing digging into the data and seeing what's going on and why these things are happening and what we can do to prevent them. Also, the Maternal Mortality Review Committee, Healthy Moms, Healthy Babies Advisory Committee, the Maternal Child Health Coalition, which Kylie and I are both a part of, and also the Mama Health Plus agenda, formerly the New Orleans Momnibus, which is working on policy agendas to really help things surrounding maternal health disparities.
I'll just start talking about the policy initiative that Ashley referenced that we're working on. But before then, I just want to highlight how power imbalances creates racist policies. And Ashley covered that when she mentioned how the maternal health crisis, the part that structural and systemic racism plays in the current maternal health crisis that we are experiencing here in Louisiana and nationwide. And it's important to just see that connection between power imbalances and how they create racist policies and how those racist policies in turn creates health disparities. But one thing that I just like to keep at the forefront of my mind and recognize that those past political actions can be undone when we are deliberate in our current political action. So our current efforts in the policy initiative that we're currently working on. Okay, here we go. Okay. And so these next two slides will cover the Black Maternal Health Caucus's Momnibus. And I wanted to give this background because our Mama Plus Health Policy agenda is loosely fashioned after the Black Maternal Health Caucus Momnibus. So the Black Maternal Health Caucus Momnibus is a package of 12 bills. Each bill was introduced individually by members of the Black Maternal Health Caucus, and it was created to address the Black maternal health crisis that exists across the nation. And there are two versions. There's the 2020 version and the 2021 version. And I will say that ours was based off of the 2020 version. And the 2020 Momnibus was introduced by Representatives Alma Adams and Representative Lauren Underwood, as well as now Vice President Kamala Harris. And the 2021 version was introduced by Representatives Adams and Underwood, as well as Senator Cory Booker. And I'm just going to just read through their titles. They have 12 titles, and each one of their titles is associated with one specific piece of legislation. So their titles include areas around social determinants of health, community-based organizations that are working to improve maternal health, looking at maternal health risk facing pregnant and postpartum veterans and supporting the VA maternity care coordination programs, growing and diversifying the perinatal workforce, improving data and collection processes and quality measures, supporting moms with maternal mental health conditions and substance use disorders, improving healthcare for incarcerated moms, investing in digital tools that will help improve maternal health outcomes, promoting innovative payment models, investing in federal programs to address the unique risk for and effects of COVID-19 during and after pregnancy, investing in community-based initiatives to reduce the level of and exposure to climate change related risks for moms and babies, and promoting maternal vaccinations. And I want to mention that the last three titles that I mentioned with the asterisks beside them, those are the additions to the 2021 Momnibus. So the first 9 titles are what was included in the 2020 version of the Momnibus. So now I will move on to the Mama Plus Health Policy Agenda, which is what we're working on. So representatives from the National Birth Equity Collaborative, Birthmark Doula Collective, and the Institute of Women and Ethnic Studies all came together for the Mama Plus Health Policy Agenda to address the Black maternal health crisis that exists in New Orleans and across this state. And one thing that we wanted to make sure our policy initiative included or one thing that we wanted to make sure it did was to support and align with previous legislation. So the bills that we have included in our Mama Plus Health Policy agenda, they uplift recommendations from the Healthy Moms, Healthy Babies Advisory Council, the Pregnancy Associated Mortality Review Committee report, and the Maternal Mortality Review Committee reports, which Ashley explained, talked about in previous slides, because they all have recommendations to help improve maternal health, Black maternal health. And as Representative Willard mentioned, the Healthy Moms, Healthy Babies uplifted the importance of both doula, access to doula and midwifery care. And I want to mention a few ways that our Mama Plus Health Policy agenda differs from the federal Momnibus. So our focus is on the local and state level, while the federal Momnibus looks at things from the federal national level. And our bills aren't just one package, presented as one package like the Momnibus is. And some of the titles that we have included in our Mama Plus Health Policy agenda are supported by other organizations or people who are not a part of our work group. But we also have bills that we, like work group members, have specifically worked on. And also some of our titles have more than one bill associated with it, unlike the federal Momnibus, which has, like, each title has one bill associated with it. And our work group is comprised of, we do have a work group that has been tremendously helpful in the efforts to improve Black maternal health across the state. And the work group is comprised of people from different sectors and professional backgrounds. So we have public health professionals, doulas, midwives, we have people in academia, we have doctors, we have individuals who work at LDH, the New Orleans Mayor's Office is represented in our work group. We have researchers, people with lived experiences. We have people who work at criminal justice organizations, reproductive justice organizations, social justice organizations, maternal child health organizations, like the Maternal Child Health, the New Orleans Maternal and Child Health Coalition. And now I'll just go through our titles, and then we'll move on to look at which bill, look at some of the bills we're working on this legislative session. So we have 8 titles. Some are reflective of those titles that are on the federal Momnibus, and some titles you'll see is specific to, the local, to the local level, while others may be more specific to the state level, and then some have both local and state components. So we have addressing social determinants of health that affect maternal health outcomes, diversifying and increasing the perinatal workforce, promoting extended Medicaid to 1 year postpartum, improving maternal health care and support for the incarcerated birthing people, investing in maternal mental health and substance use disorder, treatments, improving telehealth and other digital tools, increasing payment for group prenatal care, and establishing a MCH position on the local level. And we also have a one-pager that kind of covers the background, why we created this, and the titles that we have. So this slide right here, me and Ashley will, go back and forth, just sharing information and updates on some of the bills that members from our work group have been working on directly, that are in our Mama Plus Health Policy agenda. So Senate Bill 215, which is the Pregnant Workers Fairness Act, and that bill was sponsored by Senator Barrow, and it was created to provide accommodations for pregnant workers. And this bill would fall under our social determinants of health title, since social determinants of health really focus on your lived and work environments. And it's currently on the Senate floor.
Another one of the titles is HB 146, which is a tax credit that's received for those who have experienced stillbirth. It's under the maternal health titles and was led by Representative Hilferty, who worked closely with Saul's Light organization, also to provide financial support for families that have experienced stillbirth, which could be used to help access support and care from mental health from mental health professionals. This passed out of the House and is currently in the Senate.
Representative Willard shared information about House Bill 190 that we have been working closely with him on, and House Bill 468, which is around Medicaid expansion to 1 year postpartum. And that bill is sponsored by Representative Landry, and it would expand Medicaid up to 1 year postpartum. And as Ashley mentioned, a large portion of maternal mortality incidents occur in that year after giving birth. And this bill would allow for continuity of care and serve as a way to kind of capture maternal warning signs and symptoms before they lead to adverse or fatal events. So some of those symptoms could be swelling or fainting or dizziness. And it's waiting to be heard in the House Appropriations because there is a fiscal note attached to it.
Also, House Bill 495, which is a collaborative practice agreement, increasing and diversifying the perinatal workforce title, which was introduced by Representative Ivy, and would allow nurse practitioners and midwives to practice without a physician's supervision, also to address the obstetric deserts across the state. This has been passed out of the House and it's awaiting Senate Health and Welfare Committee.
We have also been working with a couple of representatives on resolutions. Neither one of these resolutions have been filed yet. So the first piece that I will touch on would be maternal mental health resolutions that we have been working on with Representative Duplessis. And there will be two resolutions, one that focuses on creating a maternal mental health task force, and the next one would be focused on maternal mental health screenings. And the next resolution would be, we have been working with Representative Landry on a study resolution that would focus on maternal health and incarceration. And this is our last slide, just highlighting ways that you could be involved. So you can sign up for action alerts around the Mama Plus health policy agenda at the link that's included in this slide. And it's from the New Orleans Maternal Child Health Coalition's website. They have been a tremendous support in our efforts with the Mama Plus. And if you sign up, you would receive Action Network alerts as we move through session. You can reach out to your state legislators to inform them on why issues are important. And we included the link on how you can find your own legislator. Legislators love to hear from their own constituents. And you can share another way that you can be involved is sharing the information with your community, people in your home, in your networks, families, your family members, and you can also spread awareness on social media. And the New Orleans MCH Coalition's Instagram and their Facebook, they have led our social media campaign around our efforts, just highlighting the importance of certain bills and also connecting them with maternal health outcomes, especially those social determinants of health bills.
Also, Kylie listed one of my favorite quotes. Oftentimes people ask us about how can I get involved? What can I do? And also, I love the quote, if you've come here to help me, you're wasting your time. But if you've come because your liberation is bound up with mine, then let us work together. We love for people to get involved, but you getting involved just because it's interesting is not enough. We need you to have a connection to it. We need you to be serious about it. We need you to talk to. Oftentimes people say, what can I do? And aside from donating money or supporting any type of support you can do, I always say, talk to your family, talk to your people. That's what you can do. When you're at the dinner table with your friends, when you are at Thanksgiving dinner, when you are having drinks, talk to them about the disparities that exist so that they can continue to hear these things, not just from Black women, so that they can continue to hear these things and realize and understand what's going on and why it's important from their friends And that's oftentimes who we are able to hear things from the best, people who we identify with, people who we know closely, people who we trust. So I always encourage everyone to do that, to start in your own backyards and reach out to your people and have those conversations.
Thank you. And this is all of our information where you can connect with us on social media, Facebook, Instagram, and Twitter. These are our handles and our websites. And I also included information on the Institute of Women in Ethnic Studies because they played an extremely integral part in the work that we're doing with the Mama Plus health policy agenda. And I am going to stop sharing my screen.
Thank you both so much. That was amazing. I didn't actually ask you this beforehand, but if you would feel comfortable sharing the slides, I think that some people would be really grateful to have them. I tried to put in the chat a lot of information and links to where people could find some stuff that you all were talking about. But that was just really, really fantastic. And I'm
amazing presentation, ladies. Amazing. Comprehensive, full of information. I'm definitely stealing them slides. Okay. Yeah, very, very, very well done, ladies. Kudos. Congratulations.
Well, so that is the lovely voice of Ms. Robin Barber, who is going to be facilitating our Q&A. So I am going to turn it over to Robin, and if folks have questions, they can type them in the chat. We have a little bit of a small group tonight, so I think it might not get too unwieldy if people just want to unmute themselves and ask a question, but we'll turn it over to questions.
Well, I have the first one, if you don't mind. Ashley, in your presentation, you talked about having actual nurses on staff now. Are you getting nurses to get on staff now who can actually do assessments and stuff like that? And some are being trained to do certain stuff, read blood pressures and things like that. Who are they getting this training from, Ashley?
Absolutely. So we actually only have one nurse on staff. So we have a nurse advocate who is actually a registered nurse. So that's where her training came from. She's a registered nurse, and she's actually doing home visits. The perinatal community health advocates are not nurses. They are doulas with additional training. And we have worked with Sister Midwife Productions. I think Nicole may be on this call as well, but we've worked with them. And in addition to the doula training, they've also received training in advocacy and outreach. And they continue basically to be able to branch off where their interests lie mostly, but they also have been able to receive training from our nurse advocate. And we say a nurse advocate, she is a registered nurse, but she is our nurse advocate in the sense that she goes into our community and works with our clients to find those outlying needs and really find people, especially who are at risk.
Gotcha. A follow up to that, I don't mean to hog everybody's time, but
no problem.
Supposedly, and I have yet to be able to, present to this group. I understand that there's supposed to be a Black Nurses Association here in New Orleans or within the state. Have you guys presented to them or know about them or would like to present information to them or think that would be helpful so that we can get, more nurse practitioners or RNs and LPNs to assist you with the very, very important work that y'all do?
We definitely would love to have a relationship with them. If there's anybody on the call who would like to weigh in on that, please feel free to. I'm not a nurse, so I definitely am not exactly sure about that organization, but I know there are several Black nurses who I believe are in touch and who organize in some way, but I'm not sure of the formal organization.
Yeah, well, I'm gonna still look for them.
Robin, we do have a Black Nurses Association. It's very small. I have not been in touch. At one point, one of my former work friends / supervisors / Mentors was the president. This was a number of years ago at this point. And I'd spoken with her. She's an OB person. So I'd spoken with her at length about wanting to get the Black Nurse Association involved. But they also have national agenda platforms that they deal with. It is very likely that right now they are dealing with maternal mortality and birth outcomes more nationally, because that's all the rage right now.
Yeah.
And so it could be a good time. And so I do have relationships with the person who I have a relationship with has been very active at the local and national level. And so it could be that it is a good time to reach back out to them.
Well, if you don't want to do it, I'll do it. I mean, I want to also be able to present to them about Lift Louisiana, but maybe we can do something together.
For sure. Let's talk about it.
Okay. All right. Sounds good. All right. I'm going to stop hogging. If anybody has any questions, now's the time to unmute yourself and ask these women some great questions.
So I have this is Michelle. I have a policy nerd question. We, like you all, are working on a lot of bills this session. So we are, I haven't been able to watch the hearings for every single bill that's gone through. But I wanted to ask specifically about the conversation around the collaborative practice agreement. Because I know that has been something that I've talked to the two of you about. It's something that I've talked to Nicole about, and how the way that whole system is structured, continues to be a barrier for midwives. So I guess I wanted to see if y'all could kind of nerd out a little bit for us on what the idea of collaborative practice agreement is, how this is kind of a barrier and keeps sort of the board certified licensed physician community sort of in control and in a position of power when it comes to birthing. And then I think that there was some opposition to removing that. If y'all could talk a little bit about that would be great.
So Kylie, you may be able to speak to the more technical piece of it, but I can talk a little bit about the philosophy behind it. And once again, if anyone wants to chime in, basically, especially for nurse midwives in a hospital setting, nurse midwives and an OBGYN do the exact same thing when serving a birthing person. So they both have privileges to deliver. They both see the client from start to finish, so on and so forth. And what happens is the nurse midwife is actually having to have this collaborative agreement and this partnership and this almost have an OBGYN to sign off on who they can see and who they cannot. So it's having your direct competition to say who you can serve and who you cannot serve, which has created a problem for nurse midwives in that sphere. So that's the philosophy behind removing the collaborative agreement.
Yes, and I'll also add that yes, nurse practitioners and midwives, they have to have this agreement with the physicians in order to work in Louisiana. There are other states who also have collaborative practice agreements. I cannot name them off of the top of my head, so I will not try. But that definitely limits where people can go. And also some of these physicians require the nurses to pay for their collaborative practice agreement. So that's another barrier that people have with working. I know in the initial hearing for the CPA, there was a NP who worked in mental health, and he mentioned the area that was his hometown, he couldn't find a physician to get under the collaborative practice agreement with and do the work that he intended to do. So he had to move. in order to find a position, and he worked in a totally different area. So that's a barrier. And we also mentioned, it's also removing this collaborative practice agreement would allow, midwives and nurses to serve in the obstetric care desert, maternity care deserts that we have in Louisiana. And the New Orleans MCH Coalition, they wrote a white paper, and I can definitely share that with you, Michelle, to send out to other people to, send out to the participants on this call, just so that they can have more information on the CPA, because I will mention that I was not the one who worked directly in the CPA with that bill. There were other members of our work group who worked on that bill. So that white paper would be extremely informative for the people on the call to look at. And some of the opponents to this bill, I know Claire mentioned, Claire Daniels from the MCH Coalition mentioned that there was a physician who wrote a letter in the Advocate about how nurses should not have, full practice authority. And one of their reasonings was around, around pharmaceuticals, writing prescriptions. So Claire, her and another colleague that we've been working with, they wrote a letter to the Advocate, just to, let everyone, to uplift the importance of nurses and show that they are competent in doing this work without a collaborative practice agreement.
Absolutely.
And I can speak from a direct personal experience as an advanced practice RN. And so Kylie definitely mentioned about the healthcare deserts, right? So when you have to have a collaborative practice agreement, you are not, individuals are often not able to work in the rural communities where they could create the most effective change. Right. In addition to that, with the financing, and I am just repeating some of this stuff, but the financing piece, there may be only two, particularly for nurse midwives. So there are not a lot of obstetricians who are willing to step up and support the practicing of nurse midwifery. So as a result, they really have people's hands tied, and they can make determinations of how people work, where they work. They minimize the scope of practice. So like the scope of practice for a nurse midwife literally goes from abortion through newborn care and everything in between, gynecological care, and so many more things. It includes home birth, birth center birth, hospital birth. But when you have to have a collaborative practice agreement with a physician who does not, in a climate like Louisiana that does not agree with some of the things that a midwife may or may not decide to do, regardless of the fact that she's educated to do these things, that creates a barrier. We definitely know that as minority, as Black midwives, it creates increasing barriers because, we have to fight for who is going to be our collaborative practice agreement. There are fewer physicians willing to just support African-American midwives. And then another important thing to make note of is that during COVID, lo and behold, there was an executive order, an emergency order that said, wait a minute, maybe we don't need a collaborative practice agreement. And so I don't know where that executive emergency order is, but there was an emergency order that was in effect for at least a year from the governor that removed temporarily the collaborative practice agreement to show now. So to me, this is proof that we don't need the collaborative practice agreement. And then finally, so many nurse practitioners, whether they are midwives or otherwise, are writing prescriptions and doing care without the physical oversight of the physician. So even with the collaborative practice agreement, the physician is on Two Row Avenue and the practitioner is on Broad Streets. And they have no idea what the nurse practitioner is doing anyway. So this notion of we're overseeing them because they may or may not be safe is false. Nurse practitioners do have prescriptive authority, and they already have it in the state. And for nurse midwives in particular, it's only like 10 drugs you're right for. So anyway, those are just some other points.
Yeah, thank you, Nicole. I think that's so, that's so real. And then, it's really interesting because, I think sometimes you know, we get away from, you know, talking about pregnancy termination in the context of you know, of improving birth outcomes and supporting birth, right? Like they, you know, they have been so siloed. But, you know, when we look at things like the law that, you know, tried to require abortion providers to have hospital admitting privileges, to me, this is sort of the same thing. It's like erecting a barrier to accessing abortion by, you know, creating these policies that are tying providers, you know, to this system that is fundamentally unjust and unfair and doesn't respect the, you know, the choices that that people are making about their pregnancies.
Well, look, I got another question. This is Robin. Where does the AMA stand with you guys in this extremely important work that you're doing? And I know that for 10 years, when I was working in Atlanta for LifeLink doing organ donation education, the American Medical Association, which is the African American or Black arm of the Association of Medical Professionals in the United States, they used to do a conference every year around my birthday, like June 20th through the 25th in Hilton Head, South Carolina. And that was for the state of Georgia though. And every physician, I don't care what line of work, OBGYN, mental health, would come to Hilton Head and do different presentations, blah, 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 for the whole week. Where does the AMA stand in supporting the work that y'all do right now?
I mean, I haven't seen any statements come out. And I would say that they stand with, traditionally, physicians stand with physicians. And individually, people support. You know, I'm certain that that their organization probably speaks out much more about disparities and health equities than what's the big medical? I thought they was AMA.
No, AMA is the Black arm.
What's the other one?
I'm trying to think.
No, not ACOG. Like AMA.
No.
It's NMA, the national. It's the Black one. So
I'm sorry, you're absolutely right. It's
I'm
NMA.
sure that the NMA, the National Medical Association, the Black organization, supports conversations around equity and inclusion far more than the AMA. That said, when we're talking about practitioners versus, and I'm saying versus, unfortunately, because that's often how it feels, when we're talking about advanced practice nurses working collectively with physicians, they are still physicians. And so collectively,
they stand with each other. Is that what you're saying? Generally
speaking, but I saw Kylie had unmuted, so she might have a better.
No, you really said what I was going to say, that we haven't seen any support as it relates, or I haven't reached out to them around all of our bills, and we haven't seen any support as it relates to removal of the CPA.
But I feel like they're a really quiet organization, to be quite honest. I only learned of them because of a physician I worked with who was active, very active with the organization, but I didn't even know they existed. So, yeah. I do want to mention one piece. I know that I missed the presentation on the bill, the 190 bill, which is the Doula Registry Board bill. And I have not been, I give thanks for Michelle all the time. I call her my legislative pocket. Like, so whenever I have a question about something, I'll text her or call her and she brings me up to speed. And so I know that the bill has pushed through a certain phase right now, and people are very excited about it. I will say that I do have some hesitancy about the bill because I want to make sure that we're not caught in a position where either we begin to do this work and then we still have to fight really, really hard for reimbursement over the course of a lot of years, or once reimbursement does happen, it is so low that it was hardly worth the fight, because we've yet to have any good conversations about what reimbursement would look like. The other piece that concerns me is the potential the potential unintended consequence of blocking doulas who do not want to be a part of the registry. Right now, the registry doesn't exist, and doulas are already being blocked from certain hospitals. Like, I'm in conversations with Women's Hospital right now to try to figure out how to change their policy, because they have an internal policy that says if doulas have not trained with these 4 organizations, that they are unable to come to that hospital. They have to get credentialed and get an ID badge from the hospital, and they can only do so if they've trained with these 4 national organizations. So we're working to change that right now. And I'm concerned that this could be like opening a door to the possibility of all hospitals saying, oh, well, now there's this board, and in order for doulas to come into this hospital, they must register. So I just wanted to put that out there. I have a few other things, but those are a couple of the primary ones.
I understand your concerns, Nicole. And I think with this board, one thing that me and Ashley, we spoke this morning, and we talked about how there needs to be a lot more education around doulas and midwives with the legislator. But as it relates, I wasn't aware of women's their policy, and I think it's important. I know in previous conversations we mentioned like including language that said, doulas don't have to be registered. And I know in the current legislation, Representative Willard, he has some language around discriminatory practices against discriminatory practices for midwives. And I think that might be something like when we move forward to include something specific in that bill, like you can't discriminate against doulas who may not have registered with the board or the registry board. And I think that is an extremely important piece that you just brought up. I'm taking notes, so thank you for mentioning that.
Thank you. Something else that has come up, Nicole, I think as a result of even that conversation from this morning is there needs to be just a lot more advocacy. And I say that with hesitation because there has been so much of it surrounding doulas and midwives. And I also argue that they don't need to happen in the same conversation because the professions are so vastly different.
Confusion. Yeah.
Yes, and they tend to get lumped in together. So it's already this, I think, lack of knowledge from the public at large that there's more than one type of midwife. So getting that understanding out there that there are licensed midwives who can practice in a home birth setting in the state of Louisiana, and that there are certified nurse midwives who practice in hospitals. And then when you lump doulas into that conversation, especially around reimbursement, those are 3 vastly different professions that are paid at extremely different rates, have an extremely different scope of work. So there is no way, in my personal opinion, for what that's worth, that those 3 things can be in the same conversation and receive the due diligence that each deserves.
I completely agree with you. And that's in your professional opinion as well, my dear. Not just personal. You know this thing inside and out. The other thing, Kylie, since you say you were taking notes, I'll also another concern that has been raised since my email this morning that I thought about was, at some point, this board, this registry would need to be financed. Because if we have 100, 200 people listed, someone has to maintain those records. And so that now means that as a doula, I have to pay some sort of fee, which then again can become an unintended barrier to people, particularly new doulas who are just jumping into, they got a full ride, scholarship and everything to get the training. And now, yeah. So anyway, y'all have seen my emails and how I feel. I just wanted to post some of those notes on the call this evening. Thank you for allowing that.
they're valuable. And I think what all of us can agree on, at least that have been doing this work, is that we don't want to do it quickly. We want to do it with intention. And I think oftentimes there's a rush to get things just done and to be able to say that you've done something. But I think we want to make sure that we're not creating additional barriers, that that additional harm is not being done by default, and that we're really honoring each profession.
I just think this information is so critical
amazing
to Black women. Absolutely. Amazing information. And got to get y'all in spaces, more spaces for people to hear this. Because I just don't think a lot of Black people in our community know that this even exists. Okay, I do because I happen to work in it. But you know what I'm saying? And if I'm not talking about it over dinner, when family comes, like you were saying, Ashley, you know, then people are not getting the information. We definitely got to get y'all in more spaces to share this information. This is too damn important.
And to understand,
I gotta hop off. I just want to say thank you. I gotta hop off. I'm leaving for Atlanta Friday to go see my granddaughter graduate from Spelman College where her grandma went. Okay,
come on, grandma. Come on, grandma.
Congratulations,
girl. I'm over the moon excited. I just want to say thank y'all. Your presentation was solid, and we got to get this information out. Okay.
Yeah, I mean, on that point, we have definitely held you guys over the time that we asked you, which is not a problem for me, but I know we got some, you know, mamas. I'm in my off week, on my mama off week, so I'm not as rushed to get back to the parenting. But I guess I just wanted to say if there were any other burning questions that folks had on the call, or if there were any sort of last minute things that you all wanted to bring up before we let you, you know, thank you so much and then let you go for the evening.
I just wanted to, I know he isn't on the call, but just thank Representative Willard for, you know, just taking the lead on a lot of these initiatives and being such an advocate to help improve the maternal health landscape here in Louisiana. And thanks for having us, Michelle.
Thank you, everyone. This has been so awesome, and I've learned so much, and I'm just excited to hear from y'all. Thank you.
Thanks, everybody.
Yeah, so we will share out, we will get the slides from our guest speakers, and we will share those out. We'll get the link to the recording up as well. And as we mentioned, or as was mentioned, we are working on a study resolution regarding maternal health for incarcerated people. And we've had a lot of cooks in the kitchen. It's taken us a little bit longer. My goal was to have that introduced and for us to actually have a resolution number that we could share with you, but we haven't quite gotten there yet. So we don't know the exact number that we need you guys to put on your radar to help us advocate for, but we will get that information to you. I'm pretty sure that it will be filed this week. So if we don't have it by the end of this week, it'll be early next week. And you know, it's been a pleasure working with Kylie and with Ashley, and of course with Nicole on these issues. And I just really appreciate you all taking the time to be with us this evening and share your expertise.
Thank you for having us.
Okay, we will see you all in 2 weeks on May 26th for our next session of Women on Wednesdays.
Oh, before we leave, I know many people have left the call already, but I just wanted to let everyone know that Birthmark Doula Collective and New Orleans Breastfeeding Center, we are hosting the Black Birth Matters Conference. That is happening this Friday, Saturday, and Sunday. Tickets are still available on our website, birthmarkdoulas.com. So it's going to be a wonderful it's going to be a wonderful event, and it's also our 10-year anniversary. So we look forward to it. And if anyone needs free tickets. We also have some free tickets available if you reach out to us directly.
Awesome. Thank you, Ashley, so much for bringing that up. I actually had that in my notes and then forgot to share it. So thank you so much. Yes, so you can find out more information. We put the links to Birthmark's website and Instagram in the chat, so you can find more information about that. And our next Women on Wednesday is May 26th at 6 p.m. with the Louisiana Coalition for Reproductive Freedom. So you can find out what we have been doing in terms of protecting reproductive freedom in Louisiana. You'll get to hear a little bit more about some of the policies this legislative session and the organizations that are working to protect people's access to reproductive health care in the state. So thank you all so much, and we will see you in 2 weeks.
Bye, everyone.
Bye,
Thank
everyone.
you.